Hi, my name is Dan Pollier. I'm from the University of Colorado, and this presentation is entitled The Role of Leukemia Stem Cells in Acute Myeloid Leukemia. Are they a potential therapeutic target? In acute myeloid leukemia, many years of work has now led to a fairly sophisticated understanding of the leukemia stem cell population. And it is defined as the population of cells that can both self-renew and proliferate. They rarely cycle, so they're typically protected from standard conventional chemotherapy. And this is this population that's felt to be the source of relapse when relapse occurs. The leukemia stem cells are likely derived from normal hematopoietic stem cells and other early precursor cells as a result of mutational events. And phenotypically, these can be very heterogeneous. We define them in the lab as the population of cells that can engraft an immunodeficient mouse model. From a theoretical hematology perspective, without thinking about any particular drug, what if a drug could target the leukemia stem cell population? What might you see in the clinic? You might see that responses in the first-line setting are more active than in relapse disease, and that's because of data we have that the leukemia stem cell population at relapse becomes much more heterogeneous. You might see that responses occur across all subgroups, even those patients that don't have good responses to chemotherapy like complex karyotype and other particular mutational subgroups. You might see that responses are very durable, and you might see that there's a need to pair these therapies with a debulking agent if they're only selectively targeting the stem cell population. And you might see that there's the potential with a stem cell-directed therapy to cure a patient's disease. You also might want to consider a maintenance type setting in the patients who's achieved a remission but has minimal or measurable residual disease to try to mop up some of that residual disease. So with respect to thinking about how to target the leukemia stem cell population, we have to think about what the weaknesses of that population are and how might those weaknesses be distinct from normal hematopoietic stem cells, because targeting leukemia stem cells with a strategy that also targets normal hematopoietic stem cells would be quite toxic. So first, let's think about CD33. In some cases, it's felt to be a stem cell target, and gemtuzumab targets CD33. We now know that with long-term follow-up in some studies, there was an overall survival benefit, and there wasn't necessarily a response advantage in real time. So this is a clue that perhaps gemtuzumab in some patients is able to target and limit the leukemia stem cell population. Other strategies, glastigib, which is an inhibitor of something called smoothened, which is an enzyme in the Hedgehog signaling pathway. This is a pathway that's active during fetal development, but then typically in most adult or non-fetal cells is turned off, but they can be reactivated by cancer cells, in particular stem cells. And it's felt that there's the potential that this could target the leukemia stem cell population. And when paired with low-dose in older unfit patients with AML, we now know that there was a survival benefit compared to low-dose alone. It's been several years since CD123 was identified as a potential stem cell target, and that it was overexpressed in that population. There have not been very successful attempts to target CD123 with a naked antibody, but a recent antibody drug conjugate of CD123 was developed. It was, however, stopped in the early phases out of concern for toxicity, but there are other strategies coming on using CD123 as a target that are compelling. There are many others listed here, TIM3, CLL1, IL1RAP, and all of these are in various stages of clinical development. And the other one to spend some time on is venetoclax. In 2013, BCL2 was shown to be overexpressed in the stem cell population. Venetoclax is a very potent inhibitor of BCL2. Preclinical modeling of venetoclax and other BCL2 inhibitors suggested that this could target the stem cell population. As a single agent, the venetoclax clinical trial in relapse refractory AML patients had only about a 20% complete remission rate. But when combined with a hypomethylator or with low-dose cytarabine, in the upfront treatment setting for older AML patients not not suitable for intensive chemotherapy, there's a very high response rate and deep and durable responses. So there's a clinical suggestion that you're targeting the leukemia stem cell population. And this mechanism has been under study, and there's now some data to show that this combination can target the leukemia stem cells in a very novel way. And that's through inhibition of oxidative phosphorylation. Oxidative phosphorylation is required for leukemia stem cell metabolism, but not normal hematopoietic stem cells or other normal cells. So this is really the potential for a new mechanism that specifically targets the leukemia stem cell population and explains these deep and durable responses with venetoclax, specifically with azacitidine. So leukemia stem cells are an important population of AML that's not readily amenable to conventional therapies. Many novel strategies can be employed to eradicate leukemia stem cells that are now in clinical development. It's a very exciting time. Venetoclax appears to target the leukemia stem cell population by reducing oxidative phosphorylation. And this is relevant in AML because although many drugs have been approved or on their way to approval, the clinical significance of those drugs might be lacking. So what do the results of this study mean for those treating patients within this disease state? Targeting leukemia stem cells may be a way to markedly impact the clinical significance of the treatment of AML. Thank you.